Okay, hi everyone. This is Kristen. I am just going to do a training that is recorded over our closed system transfer devices and our hazardous drug compounding at our hospital. This is an added safety component that we are going to be utilizing and have been utilizing for our hazardous drugs, but I just want to go over this a little bit more in depth. So what are CSTDs? Also known as closed system transfer devices. It's a type of containment device that's supplemental to our engineering controls in our hoods. It provides an adjunct control to offer an additional level of protection during compounding and during administration. So USP 800 requires that we use CSTDs when we compound anti-neoplastic HDs, when the dosage form allows, and when we administer anti-neoplastic HDs, when the dosage form allows. So at our site, we use the BDD Facile Optima system. A little picture over here to the right that shows all their different devices that they have in different sizes. Currently, what some of you may be familiar with, and I know some of you have had to do, is we use these to prepare our methotrexate syringes for IM use. This is indicated during a tubal ectopic pregnancy. The dose is 50 milligrams per meter squared. OB does prefer that this comes to them divided into 2 syringes. We attach the needle, we have it ready to go, ready for them to administer when we give it to the provider. Currently, only our OB-GYNs administer this. Our midwives do not. I have trained all of our OBs on what this will look like when it comes to them in these syringes. So they know that's going to have the device attached to it. I have not trained our midwives because Dr. Hubert has told me that they will not be administering those. If that ever changes and you receive an order from someone other than an OB, then you may need to kind of show them about this. Methotrexate must be prepared in the CPEC within the negative pressure room. That's our left side. We call it our chemo room, our chemo hood, whatever you want to call it. No exceptions. It must be prepared in there once we implement all of these policies, just like we've currently been doing. But I just want to emphasize that this is one of those anti-neoplastic medications that we do not have any wiggle room on. Special attention to this slide, but CSTDs should be utilized for any medication noted in our risk assessment tables as a moderate risk. So if they have that orange little coloring on their table, pay special attention. If we have a closed system transfer device available for that product, we need to be using it. So some things off of the risk assessment is IM methotrexate, IV estradiol, IM or IV fosphenytoin, IV ganciclovir, IM medroxyprogesterone, or sometimes we call it Depo, IV phenytoin, and IV zidopudine. If the medication listed as a moderate risk is not life-saving, it shall be compounded in that negative pressure hood. So IV estradiol is ordered, IM medroxyprogesterone if we are completely out of the pre-filled syringes, which I never hope happens. Something like that. It's not life-saving in the moment. We need to go into the negative pressure room and compound that. If the medication ordered is life-saving, immediate need, and it is moderate risk, so an example could be fosphenytoin. If we have someone in the ER that we aren't able to use IV Keppra or phenobarb or something, that we would prefer over fosphenytoin, then and you don't have time to get in the negative pressure hood, you may compound that as an immediate use, but you still need to use closed system transfer devices. So what you would do is you would use one of our disposable spill mats that we have that you should be using if you ever have to cut or split the misoprostol tablets or something of that. You put that disposable spill mat down on their counter, just like outpatient does. And you would compound it with the closed system transfer devices just right there over that disposable spill mat. And then everything, the spill mat, everything used to compound, and your PPE, you're still wearing the appropriate PPE that you need to wear for that, will go in the yellow bin. So how to prepare an IM injection. I know that I've gone over with most of you probably, and you may have done demos, but again, we do this so far and few in between. It doesn't hurt to have this additional training, and you are more than welcome to always do some more demos. So first step to build this with the Facile Optima system is we're going to have our syringe, and we're going to have the Facile Optima injector. So first, you want to aspirate air equal to whatever drug dose or diluent you are going to be drawing into a syringe. Currently, none of our products require a diluent. It's all in solution form, but just keep that in mind if you ever need to use a diluent for something that is hazardous. And then holding the blue hub of the injector is a luer lock system. It will luer lock onto your syringe. So just ensure that that is securely tightened on there. Sorry, these pictures are blurry, but I will go through a video as well. And then we're going to assemble the vial and the Facile Optima protector. So you're going to remove that vial cap, disinfect it just like we normally do. Remove the bottom cap of the protector and push it straight down onto that vial. I kind of think of it like a mini bag, how you press those mini bags on. That's usually kind of what it's felt like to me when I put these together. Third step, we're going to attach both of these components together. So you'll take the end cap off of the connector and off the protector, and they just push straight together. So leaving that vial straight down on your table or your work surface, push straight down the connector on that, and it should snap it in place. You can then push the air into the vial, and you should see the little bulb. It will inflate, and that shows you that the air has been placed in there. Then you're going to invert this system, aspirate the drug dose into the syringe unit, and the expansion chamber will deflate because that air is going back up into that vial. When you've got the appropriate amount of drug into your syringe, re-invert it back, place the vial on your work surface, and you will pull straight up to disengage that syringe unit from the vial surface. Now, you never remove that connector, that blue and white piece. Once it's put on this, it stays on there. It's a mechanism to protect you, to protect the nurse, to protect the physician from that drug coming out of that syringe. So that's why you want to make sure it's securely tightened and it does not ever come off of the syringe. When they are done administering this, or they're done giving an IV push, or however the drug is administered, this whole thing goes in the yellow bin. They never have to detach the syringe. They never have to detach the needle. It all goes in the yellow bin. So the luer lock is also required to put the needle on. So we're going to add in a third piece, which is the Facile Optima connector, which is this little piece here you see on the left. You'll take the cap off and it snaps right onto that connector, just like the connector did to the protector. I know this is a lot of words, but hopefully you guys will practice on the demos and you'll watch this video and it'll make a little bit more sense. And then at the end of that, it has a luer lock and you put the needle on and it is ready to administer the drug. So the practice example is the same practice I gave you last year. If you have any questions about calculating a dose for methotrexate or anything, just pause this video, look at this, or give me a shout. This is what the final product should look like. This is what I did when I did a demo. It will look like this when you provide it to the person administering, in this case, methotrexate. So that's why I put the OB physician. So you would want to give it to them in 2 identical syringes, because they're not going to give, like a 4 milliliter IM injection. They want that divided into 2 equal parts. How to prepare an IV bag with the closed system transfer device. This is something that I have not gone over with you yet because it's not something we really implemented. When our policies go into place, we should be utilizing this as well. And it's really pretty simple too. So you're going to prepare your syringe unit. You prepare that exactly the same way that you prepare for the IM injection. You've got the connector, and you've got the protector. You're putting that on the vial to get the drug out of the vial. Then you will disengage it from that vial and the protector, and we'll be using that to put into the bag. So in addition to the syringe unit preparation, you're also going to need tubing. So just our standard hospital tubing, like I've got pictured here, our Plum 360 tubing, and the BD Facile Optima infusion adapter. The only other time that you would need something else is if the drug requires a filter. So that's going to be drug specific. If you need the filter, go ahead and grab the filter and take it in there with you as well. This is what the infusion adapter looks like. How to prepare that IV bag. Place it down on a flat surface, or some of you I know like to hang it up, but they do prefer on a flat surface. Spike the IV bag with that infusion adapter. They say that it should be over the shoulder of the infusion adapter, and this is a little bit easier to see whenever I show you the video in a little bit. If you are priming the IV line, which we always will be, Because when we want to do that, you'll spike this little blue hub on the infusion adapter, and that is where you spike the tubing into that adapter administration set. And we usually like to say prime the tubing with the solution prior to injecting the medication into the IV bag. And that's just to ensure that we've got that good flow, got everything going, and that you're not wasting drug if something were to happen and we, mess something up. So I do recommend priming that tubing first. Then once you do that, you will engage the prepared syringe unit to the side of that infusion adapter. So just like deconnected from the protector, which is on a vial, it's going to connect right into this infusion adapter. Once those snap together, you will push that drug into the IV bag, disengage that, and if you need to, inject more medications, blah, 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 you'll just keep repeating these steps until you have the correct amount of drug. And then it is now ready for administration. You'll dispose of your syringe units like I said earlier, without disassembling, into the yellow bins. Then you will provide this to the nurse that will all be attached, and all they have to do is hang it up and give it straight to the patient.